Hi, everyone. This is Lucas Voss with Becker's Healthcare. Thanks so much for joining us for today's webinar, The Data Problem Standing Between Your Organization and AI That Works. Before we begin, just a quick few housekeeping instructions for you all. If you have any questions for our speakers throughout the webinar, please feel free to type them into the Q&A box you see on your screen. We can follow up to get you an answer there. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that same recording. If at any time you have any issues with audio or visuals, just try refreshing your browser. That generally helps. You can also submit any technical questions into the Q&A box. We're certainly here to help. And with that, I'm so excited to have such a fantastic group for this very important discussion here today. We'll cover a lot of ground, but I do want to start off with introductions for everyone. Dr. Gleber, you're first on my screen here. If you want to just go ahead and introduce yourself, give us a sense of your role and your organization.
So, Dr. Conrad Gleber, I am ACMIO at the University of Rochester in New York, and I'm also the Associate Director of the Health Lab, which is an innovation lab at the institution as well. I mainly focus on the strategy for data and analytics at the organization, which is why I'm here. And we talk a lot about infrastructure and how to get data to the clinicians at the bedside as much as possible.
Great to have you. Thanks for being here. Dr. Weber, over to you.
Hello, I'm Emily Weber. I'm the CMIO at Indiana University Health, a pediatrician by clinical background, and I get to work on our clinical AI strategy in emerging areas as well. So today's topic near and dear to my heart, and I'm looking forward to sharing, but also learning from all of you about how we tackle this together. Thank you.
Certainly very interesting in the pediatric space right now, so I'm sure we'll hear about that here in a little bit. Dr. Valerian, over to you.
Hi, good afternoon. Dr. Al Valerian, Vice President, Chief Medical Information Officer with Northwell Health. We're part of Nuvant's northern region. We've just went through a merger, so now we're integrating a lot of our workflows and systems. And data is probably the most important lift to collaborate and patient care access throughout now a much larger territory. So I'm very glad to be part of this and understand how other systems do it, but as well as discuss how we're planning to do it as well through cloud and AI interactions. So thanks for letting me be here.
Great to have you. Great. Excited to hear about it. Dr. Chada, over to you.
Thank you, Lucas. Ramal Chada. I'm a practicing hospitalist and also serve as Chief Medical Information Officer for UK Healthcare. Some AI, some data, some here, some there. So all parts involved.
I'm sure we'll hear about all the parts here in a little bit. Last but certainly not least, Julie, over to you.
Oh, thanks. So I'm Julie Smith. I lead global healthcare market strategy for InterSystems. And, we're a technology vendor. So we really think about it in terms of how do we provide the best services. And many of you may know InterSystems. In fact, many of you are our customers because we do sit as the foundation of Epic and the VA and many other large healthcare entities. And so this is really relevant because we deal with data day in, day out is what we live and breathe. And how do we make it actually usable in the world of AI is a big question.
Yeah, and I'm sure we'll hopefully answer part of that question here soon, if we can answer it. I do want to start us off with sort of level setting the conversation a little bit again, because we have so much ground to cover. We know, again, some of you have mentioned it, certainly AI adoption is accelerating across the board, no matter where you look right now. But again, oftentimes what we see is the conversation jumps straight to the technology in and of itself. So what are we using? What does that look like, et cetera? I'd love to know from your perspective, how often is actually data readiness the real limiting factor today? And what does it look like when an organization charges ahead without having that data foundation ready to go? Dr. Weber, can I start off with you? Because again, this is, I think, in a pediatric environment, this is very important.
Well, and I appreciate the recognition of the pediatric environment. That is a short path to every pediatrician's heart. So appreciate that. But I'm eager to hear from the other speakers. But I think that I think you hit the nail on the head that we've moved on, I would say, from a year ago, 18 months ago, where I think people overall in healthcare have what I might call a healthy skepticism at this point about what AI value is being delivered. And you really described it well that I mean the data is the fuel for this element. So if anything, it's at my organization definitely helped us drive a clear focus between things that might have felt a little invisible and a little distant from some of those clinical innovations in the past, and it's getting very real. So if we want to do things, and I'm not talking about maybe ambient scribe and things like that, but some of those more maybe AI unique opportunities for us to draw insights have really forced us to look at not just our own data warehouses, but as was mentioned, like our partnerships with our core vendors and kind of that being ready for that. I think we're at a point now where we've had a few major wins in some of our ability to scale some key use cases. And I think I'd like to say on my optimistic days that we feel more inclined and more focused on those places where we want to use our AI and therefore preparing that data for that need. But that really, you don't just prepare one part of your data. Like it really for us has set off sort of a modernization overall so that we can be ready for the tools that we want to apply there. And that has been new partnerships formed internally and externally where we're not, I don't know of anyone who feels like they have the capacity in their operational teams to do this additional element of what it's needed. It's just now more part of operations than it ever was before. So
Yeah, I'm glad that you mentioned the different use cases because again, it's so important to recognize where it sits and how it is applicable across the organization with different use cases. Dr. Gleber, would love to get your perspectives on this as well. Again, how often is that data readiness piece the limiting factor, right? And what's the consequence of going ahead without it?
Yeah, I would actually probably say that this is far more often than anybody talks about as one of the primary key issues that slows us down. So we start by trying to implement the end product, like we buy a product from somebody, and then it takes 8 months because we can't get the pipes to work to flow the right to the right places. We learned that the hard way. I'm pretty sure all of us probably have experienced that, where we wanted something, and then some of our teams said, "Well, we don't do that. We'll have to learn how to do that, and then it'll take a while." What we've I think it fails predictably because we weren't ready and we learned what we needed to know. And then charging ahead, we leaned on our vendors actually. So the ones that became the closest partners with us could offer us a new product, which was a platform that helps communicate with everybody. So if it's working with just something that is much more broad that we can use their expertise to help us get there, because internally we have a lot of stuff to maintain. We can't become new cloud engineers and all those things all at once. So we rely on our vendors to help us, and it is much more common than people talk about. It is boring, which is why people don't talk about it. It's much more fun to talk about the end products that you're getting than it is to talk about, I don't know, how you define length of stay in this column on this table that you need to move over to some vendor.
Yeah, absolutely. Dr. Valerian, same question for you again. In your experience and from what you're seeing today, right, within the organization, but in general, also historically, how important is that data readiness piece for you? And again, have you had the experience of, again, charging ahead, right, without that data? What does that do?
Yeah, it's creating a data cloud, the data lake, however you want to call it, internally was a priority for the last 2 years. And then we looked at, hey, we're going to have a merger now, even more so, the importance of having that ability to share that data. So we processed that data for our utilization, but rated it for sharing with an integration process moving forward. What we found is that there's more information than we ever thought there was. So there's new data elements that are coming out that are impacting change. Like if you have three elements of a diagnosis and you have a blood test that changes that diagnosis, that's an important piece of information that you want. But we're seeing this across the board. So now that we turn on the engine and have that interaction with our new data, now we're processing more information, which, like I said, like has been discussed, relies on third party to support that, but we ask the questions and we feel that we create the view of relevance. Meaning, I want the clinicians in the ED to get different information than the clinicians in the cardiology department different than the clinicians in pathology, because those are the aspects that are subjectively important for the end user's use and maximizing their use of that data. So now we want to look at creating these filters so that if you're ED physician, you want this type of information coming through the AI agent into the EMR versus a different kind of practice. And that's how AI and data work together. But there's also the third aspect is the patient information. What they're putting into the system now is becoming more and more relevant because we can extract that and integrate that into the differential workings of a clinical interaction between patient and physician, a clinician.
Yeah. I always wonder if the data lake is a great vacation spot. Maybe I should buy a cabin on Data Lake.
You would.
It sounds very lovely. Dr. Chada, I saw you smiling through most of your colleagues' comments here. I'm sure this is very similar to you, but would love to get your perspective as well.
Yeah, I'd like to start with a question. If all data was streamlined, as Dr. Valerian was saying, that ED and hospital medicine, cardiology, all should be able to see same information. If the data was similar, then why merger and acquisition and going to the single instance has all the rework and the waste and reprogramming involved? It is because each organization, each site treats themselves as very separate. Everyone believes they work the hardest. Everyone believes that their patients are the sickest. These are just human, and they are unique. They like that's just the given part. So that's why I was laughing, because I completely agree with Dr. Valerian's point that the same data has to go to every place. UK healthcare has had the journey of enterprise data warehouse for more than a decade now. So when we were moving from paper to some paper, most electronic to all electronic, almost 14, 15 years ago, we started to have a data warehouse where we were able to get almost every EHR data. And then recently, as Dr. Gleaver has said, the name of the two companies, we picked one of them like some time ago, and then have created modernized version of enterprise data warehouse, where the structured data which exists, but unstructured data also can exist. Now, the phase which we are in is that there are many machines which we use or other technologies like just badge, like swap in and swipe out kind of thing, or electronic ICU or EICU based device data, or CRRT machine data, or nurse pump integration data kind of thing. Those are the things which we are trying to manage and get converted to the same modernized data warehouse. So those are the current challenges, that we don't have data for every machine, bits and pieces, human movement, other things around. So those are the newer challenges now for us.
And I think that's what makes this very interesting too, is because it moves so fast, and it's a continuous process. It has to be treated as a continuous process. Julie, for you too, right? Are folks understanding that this is something that needs to be treated as sort of a foundational issue? And again, from your perspective, where you're sitting, again, how is that data readiness? How often is that data readiness the real limiting factor?
Well, I think that, I think some of what I've heard is very much what we hear across the board. That data, we've piped it somewhere, we've put it somewhere, it is there. We might be adding feeds to it, and we might be taking some away, but it's not always fit for purpose. And unless we know what problem we're trying to solve, and then actually applying the solution to it, that is a really late stage to determine, wait, our data was never ready in the first place. And I think that, to Emily's point, we sort of hit that point in the hype cycle with AI. We really just thought we could use AI and it would solve it all. And now we all understand that AI is not going to solve it all. The data has to be clean, because garbage in, garbage out. And so now we have maybe a different definition and understanding of what data readiness really means. And it needs to be use case specific, right? I mean, how the timeliness factor, the quality of it, the comprehensiveness of it, right? It varies if you're going to do an ED summary versus, a pediatric one. I was an ER nurse for many, many years. I want to see something different, right, when I'm triaging a patient than when somebody's in a clinic. And so not just understanding what needs to be surfaced, but way earlier, right, when it starts going through those pipes, what do I need to do to it? And what we've heard across the industry is that we've started to realize we need to clean it up. And we actually are doing a lot of that cleanup manually, which is absolutely not sustainable. That we have to have ways to clean it that are automated, that have quality assurance around them, that are transparent, so that then we know when we apply AI to it, what's happening, and we can trace it back and have that validation that's required.
I'm glad that you mentioned the scalability of it because, again, it isn't sustainable in the way you've described it, most certainly. And again, a lot of these initiatives, it sounds very straightforward. Okay, we'll just get it done. Here we go. But again, if we're looking at it from a scale perspective, from a scalability side of things, it's very hard to do. And again, we think about there's a couple of words here, right? Connected, current, reliable, easy to use. Those are things that, again, sound very straightforward. They sound like they should be easy to achieve, but it's not. At scale, it's incredibly hard to do. And I'd love to know, Dr. Weber, I'll start off with you on this one. Where are most health systems falling short today, you think, and which of those gaps tend to create the most downstream pain for AI initiatives?
I think I'm both, as always, kind of reassured hearing my colleagues say kind of where you all are as well with things. I think that where we're falling short is that kind of to Julie's point, it's a very familiar territory of like this technology will solve this complex problem. And I think where we are now is we're still refining our sense of trying to use the appropriate AI tool in the appropriate context and use case and manage that risk as well. You had a few really kind of take off in the clinical point of care, but in some ways, and I know I said ambient before as well as the most forward-facing generative feature that our patients are seeing every day in their care and that we're most familiar with. But to be honest, although that has been life-changing for a lot of our clinicians, and I'm not suggesting for a minute it should be, like the ability to actually eat dinner should not be something that should wow us, right? That should be table stakes. And so that's a good thing, but it's also kind of just applying the tool to the same process. And so where we are now, I think, is starting to really challenge the idea of what work is best suited and really requires the true clinical, not just clinical judgment, but we used to just say human in the loop. I think we're refining that more to say what that really means. I think most of the clinical use cases are starting to emerge of things that we cannot do this without AI versus AI would help me do this same process faster. And really kind of trying to frame that as value creation and value capture. I think a lot of us are still having to do, I don't know about all of you, but some of our dependencies as a health system include things like making sure that we're paid for the clinical care we provide. And there's a little bit of an arms race of kind of run the business tools that you have to consider. But for the pure clinical aspects, I think we're getting better about saying, I always call it my Jurassic Park question, just because we can doesn't mean that we should. Like, is that the right place to put not just the tool and the financial elements of buying said tool, but our effort in cleaning our data and adopting it? Because I think we're getting more refined on that. And I think a lot of health systems, ours at IU Health, we're part of a large academic and research institution, and we're finding a lot of use cases there in analysis of data that we simply could not do at scale without some of these tools. Now, that being said, I think again, I'll just reinforce, I'm grateful that the idea that we're going to deliver unhitherto value in 6 weeks, I think that started to fade. And it's like, well, it's probably things that really are impactful and transformational probably do take some time to frame. And I think that I'm grateful that pendulums swung back a bit, because the other part of this is also, it hasn't gone away that we continue to need to build trust. And as a healthcare, all of us are healthcare providers. You don't get a lot of fail fast opportunities. Like these are decisions we don't have the luxury of messing up and going back on again. So Lucas, not to get us too kind of far off scale, but I think I would say that we're in a much more deliberate place about where we want to use these clinical AI tools, even as sort of the dust settles on maybe the operational and administrative productivity ones.
Julie, can I ask you a quick follow-up here? How important is that assessment part that Dr. Weber just mentioned? Why is that piece so important?
Well, I think that part of what I heard is shiny object syndrome, which we've all experienced, right? Especially in that sort of uptick and hype cycle. But I think we probably have also all lived through the high-tech act and moving from paper to electronic workflows where we really, I remember being at an early adopter site implementation, and what we did was we mapped all of our existing workflows and said, now we're going to do them electronically. And that's how all of us started. And I think that, and many of us started with all best of breeds, right? So then we were cobbling together all of these things. And what we've learned over the last, decades is that actually we would probably want a more cohesive strategy around this. And we actually need to figure out what is it we're trying to do here and what is the best way to do it. And I think AI offers this very unique point in time to re-ask that question meaningfully. And to say, maybe just because we've always done it this way isn't the way we want to continue to do it. Can we solve this problem differently? All of that requires thoughtful, strategic thinking of, is this the right foundation to build on? Is this the data that is clean? Is it reliable? Are we following governance practices here? Do we have review in mind? Because I think it came up a little bit earlier, the vendor relationship has shifted a little bit to say, how much can I trust and rely on what you're saying, and how can we work on these problems together? Because it requires that level of trust and transparency to be able to solve these problems differently. And I think that that's really been a shift over the last 18 months when we start thinking about this. And a lot of it has come about because we've all started to realize the data may not have been ready for it, and we need to tackle this together.
Mm-hmm. Dr. Valerian, just coming back to our original questions, from your perspective again, where are you seeing most health systems falling short today when it comes to these initiatives? And again, what are some of those gaps that you've identified that really create the most downstream pain?
I think the best part of this whole discussion is the fact that we are still the human in the loop, right? We are the ones that have the clinical knowledge, that have the business knowledge, that have the technical knowledge. As CMIOs, we do all those three as one job, and we have to utilize that knowledge to apply that to the new technology coming in. What answers are you trying to develop before you put the technology in? Is it a primary care question? Is it an OR timing question? Is it a utilization question? Because you develop the technologies to align with the answers you're trying to get. You're not just going one single AI agent goes in and then you give it questions and it doesn't know what you're asking, or it gives you answers that aren't relevant to the outcomes you're expecting. So we have to be the human in the loop. We have to have the technology behind us, and we are the forward-thinking faces of yet that technology in the healthcare environment that we work in. And just like we have different leaders here, we have different environments we work in, different financial structures, different organizational structures for representation type of interaction. So we have to listen to the needs of the business, the clinical, and the patients, and they're all equal, so that we can merge and collaborate the workflows that best facilitate the specific subjective development of the utilization of the AI agents that are pulling the common data being produced from one source. That's how we're thinking about it here.
And I know we talk about the human in the loop so much. It's certainly one of those buzzwords that comes up quite a bit with AI right now, most certainly. Do you feel like leaders are still underestimating that? You mentioned that it's very important to not do that. Do you feel like the solution to it is making that a priority?
Absolutely. It's a tug of war. There's the end users pulling really hard to get everything out there, including shadow AI that they feel they need, and all the rest of us saying, hold on, let's work on an integrated process, a governance structure so that we develop and evolve the best practices of AI utilization for your excellence in clinical care that you want to bring to your patients.
Dr. Chada, what does this mean for the clinicians? Again, what does this mean for the folks that are using this, that have to be the humans in the loop, apart from leadership, of course? But what does this mean for clinicians?
Um, I think this is a tougher question, Luke. Yeah, I thought we agreed to the simpler ones.
Yeah, only simple ones for you, yes.
Yeah, but I try to use some analogies, kind of thing. The human in the loop, as well as the statement which became really popular, and it's a really catchy thing, that AI will not replace human, but a person using AI will replace a person not using AI, kind of thing.
Mhm.
I try to use some analogies like some jobs have definitely gone away. One of those was we didn't trust humans to select which elevator button they want to push. So there was a human pushing it. That job would not have been replaced by a person using AI. You just trust that human. So I think what are you trying to solve, as my colleagues have said before? I try to divide this, and I have said this in a couple other podcast webinar. I try to go to the Nobel laureate Daniel Kahneman's concept of system one thinking, system two thinking. There are some decisions which we should make by gut. There is, in the heat of the moment, fright, flight kind of thing. And then there are some decisions which need more cognitive time, and we need to put some more brain work there. Similarly, on the other axis, there are things which are value added to group. Let's only focus on physicians and APPs. There are some tasks like doing surgeries, like talking to patients, like explaining things, that human connection part. So those are all value added parts to all different specialties, versus there are some administrative, there are some things which do not need cognitive. These are just cog in the wheel buttons kind of thing happening. So that 2 by 2 table creates what we should be doing. If you take something away from physicians, which they really love and they find value, and that's their core identity, they will not be happy. Although that electronic transformation or AI makes sense, but you do that and you will have some outbursts. But at the same time, there are some things which should just happen automatically. Like, why are you asking me? Obviously, I'm in favor of that medication. That's why I wrote that medication. And now you're asking me to do the prior authorization. So some things like that, yeah, just outsource them. I don't care. I don't want to know. Like, I want my patient to get that care. So those are the things which, as a system, as a country, as policymakers, need to decide and move us in that direction. So like that's why tough questions, longer answers. Sorry.
That's the way to go. Dr. Gleber, I just wanted to get your perspective on this as well. Again, what does all of this mean for the clinician?
Yeah, I'm gonna also do a long answer, but I'm gonna go back to the previous one and help me explain the one here too. So my short version of this is, for the frontline clinician, when this stuff fails, there's alert fatigue, task switching away from an important task to an unimportant task, and they just inherently distrust the system and stop using it, and you completely lose adoption, and therefore all the money you spent on this tool that's supposed to help them goes away. And we've seen that firsthand in a couple of scenarios, and I think it's worth calling them out. We wanted to improve our online scheduling, and in order to do that, we needed to have really good data around our providers' specialty and where they work, and so location, and what their template is for those who know templates, and how they like to get scheduled. there's a lot of duplication we learned in this type of data across our backend databases. And I know everyone who's probably listening to this will probably realize like it's probably there too. We actually learned, we spent the money and learned that it's actually 5 base systems and they all had to talk to each other. And then there were multiple manual scenarios that were breaking all the time. So when a system went live for online scheduling, that included some AI, fancy AI to help optimize these things. The clinicians hated it. They completely stopped using it or actually just opted out, kind of went to their chairs to complain and says, this expletive scheduling system needs to be turned off. That was a problem that the clinicians saw, but it actually started way back at the base data system because, I mean, you give an AI a data system, it'll work through it. It's just, if it's not great, it's not going to be great. I think the same thing happened with our sepsis response system. I think a lot of it stems around how people define sepsis onset or which SEP criteria you're going to use on how you're going to alert me. In peds, the prevalence is super low, so they like want a different type of alert than they want in adults because they see sepsis all the time in adults. It's a very different subjective feeling towards sepsis. And we have lots of sepsis models over the years. And in the end, the one that won was the one that had explainability of the data behind it. And that gained adoption. That's what the clinicians saw. Then we started using it. And honestly, the other models were just as good. But this one won because people liked it and they trusted it. So I think in the end, the data, I think, was the reason it won, but it was not necessarily around data quality. It was data transparency and a shared meaning to the data that they were looking at. When they saw onset of when the oxygen dropped and they had a pneumonia, that seemed like when it started. They agreed. Oh yeah, this model actually cares about the things I care about, or the first time the lactate was high. So that's what it means to the clinicians. It's going to be they're going to hate it. They're going to not want to use it and they're going to distrust it, and then therefore we lose all the value that we've put into it.
Julie, is that undervalued? You talked about trust. Is that piece undervalued? The usability of it, again, the trust piece, the transparency piece, is that the case?
Yeah. Well, right. I mean, you can. I think that example was perfect because, you lost huge goodwill with the individuals in the organization that tried something and it failed, which we see very often in some of these initial pilots, sort of the hype around it and then the failure, and when it all really comes back to the data. And if you lose your audience too early, then your chance of proving success later is hard. But it goes to the trust, which is transparency, traceability, all of those things. I happen to be a mom of 4 kids. I don't track all of their movements all the time. But if they tell me every day they make it home from school, I believe them. And then if they don't, I have a way, if I can actually see it and I can understand what happened, I feel much better about it than if I just am sort of wondering, left with questions of what exactly occurred here. And I think that goes to that sort of hand in hand of traceability and transparency is part of what builds trust. And you have to have both. And you have to have it with a foundational base of quality for the problem that you're trying to solve. It doesn't have to be quality for all of your data in the history of ever. It has to be for this problem that I'm addressing. Do I have what I need to actually give you a robust, accurate answer? And can you see how I got there? And I think that's what we see over and over.
Dr. Valerian, did you have something to add there?
Just real quick, I think trust goes beyond the clinicians, it also with the patients, because that's how you build the unification of care. It's a relationship. It's the contract between a clinician and a patient that is trust from the beginning. And if we don't have that trust in the data, then we can't explain to the patients that I'm basing my decision on trustworthy data. Therefore, there's distrust, and that loses the patient's trust of you, your network, et cetera. So this is a very high value target. That trust has to be shared across the organizational state, but also with the clinicians who are delivering the care and the patients who are receiving it. Once you have that singular trust and understanding, then AI becomes an agent to provide the lift for all of the end users in one network. And that's how we're looking at it as a unifying factor that's vital for our survival and growth within the healthcare industry.
Dr. Weber, go ahead.
I just was thinking, as it kind of is circular as well, because as we're talking about data readiness, I just can't echo enough. Like, I think a lot of us have spent a lot of our careers in kind of the digitization of the EHR and read over and over bemoaning kind of lost opportunity to really think about places to change that. But I would just say, like, I think a lot of us are working more closely with our engineers and architect colleagues than we ever have before. And shrinking that gap between the clinical frontline and what it ends up being, it sort of forces that, because we asked, like, kind of what is you lose trust, you lose time, you lose resources that might be spent elsewhere. I just think coming back to, we all probably love governance and policies because it helps us have reliable ways to do our business. But I think sometimes we're still in a learning phase with even the most established vendors of what that data translation and readiness looks like. You want to be adopting new and innovative ways of changing the care you deliver, but you also want to have confidence that you're collecting your data and aren't going to commit yourself to a huge lift for, like, it's like making juice and you just squeeze it and you're like, one little drop, like this whole, bushel of oranges was that the right bushel of oranges to squeeze? And I think that the nice part is, I say this over and over again, I don't know about all of you, I did not major in data science or spend a lot of time writing code that is now in the space of AI. But I think that human in the loop question you asked earlier, Lucas, like, I think a year ago, 2 years ago, we're like, that's the person responsible. That's someone who's going to review all the outputs and make sure it's legit. And I think it's starting to evolve to be like, the same way we have data stewards, we talk a lot about AI stewardship now in our space. And we're like, okay, the same way you manage a human person doing this task, that we've got to start to apply those same tenets to managing our agents and these tools. And I think that goes not just to the trust element we're talking about, but if you are now the AI steward for some of these elements, you suddenly have to be a greater understanding of the data you're ingesting to drive it, which is not something we had asked people to be experts and responsible in before. And I think that's showing the maturity of our growth. This is me trying to get everyone hyped up about the let's be a steward, not just of the data, but of the AI products also consuming it.
Yeah.
I think you find the right, I will say too, though, if you find the right time, the right leader, the right problem to solve, I spend a lot less time convincing people that this is the right thing. Like, they are bringing the things that they know are going to solve the important problems, which is, I think, a very invigorating change, as challenging as it is.
I'm going to throw in one more buzzword for you all in healthcare right now, which is interoperability. Fortunately, interoperability has been a buzzword in healthcare what feels like for decades. It's one of those things that we've talked about for quite some time. I'd love to know what's changed about the urgency that we're seeing around interoperability, about closing those gaps now that AI is in the picture, and what are some strategies that you have seen move the needle in the right direction there? Dr. Gleber, I'll start off with you.
Yeah, thanks. I mean, yes, this is a classic buzzword. I defer to others to see if we've reached our goal of interoperability that we were supposed to get to, whatever, 10 years ago. But what's changed a ton is, like, how much it costs now if you were behind the times and not trying to do it already. I think we've also shifted focus from interoperability between institutions to now interoperability between providers of insert product that we are consuming. And we've obviously still want to have healthcare interoperability and healthcare exchanges so that we can get patient data from lots of different healthcare agencies, and we like try to get as much as we can. But it became just as valuable to now have interoperability with our partners, which is a classic conversation that we have of, do we need to pivot resources away from one to the other or something like that. I do think that it's another classic infrastructure. There needs to be governance over it, but I might say this is a short answer. It's just, it costs a lot to get it wrong, so you got to get it right, and we've been trying to do this for years.
Is there, just coming back to the strategy part of this, is there something that's moved the needle for you in terms of the strategy itself to solve this? Is there an initiative that made this easier?
Honestly, our vendor partners choosing a platform that they preferred helped us make our strategy of what to move forward. Oh,
Yeah.
so if we go to this platform, it's just a button click, and then you get your Delta table that you need to do the thing that you want to do. Great. Because we spend a lot of money on keeping the business running style work. Lowering the cost of that when it comes to some of these data infrastructure pieces is very valuable to us in the long run.
Absolutely. Dr. Chada, same question for you. Again, when we're looking at interoperability, why is that such an urgent topic right now, especially with AI, of course? And what are some of those strategies that have moved the needle in the right direction there?
Um, this is where I bring props,
Great. Please show them. You always have great props.
and both are both
There you go.
$40. Both are paper, similar size. What would you accept? So if these are data which are getting transferred, states are looking, federal agencies are looking, the payers are looking. If we do not have same agreed definitions, this is another work what our group did almost a decade ago. We created an internal blue book of metrics, and we call it blue because of the University of Kentucky blue kind of thing. I do see different shades of blue in my colleagues' backgrounds also. But that was one of the things that it aligned to some of the external benchmarking like Vizient, or it aligned to the CMS measures and other stuff, and creating that standard definition, which is transferred to other organization so that I can receive the same high quality data. So it becomes back and forth. Patients are not living just in one place, and they are not married or tied to one organization, one physician, one APP, one surgeon for their life. They will move around. This was created as an incentive, disincentive, carrot and stick methodology, and that methodology failed. It is something what patients, healthcare systems, CFOs, CIOs, CMIOs should demand. This is required from our vendor partners of any EHR system, that there has to be one currency which we use to transact. If we don't, we are causing rework, we are causing some waste, we are causing some harm to the patients and financial harm because of repeating things clinically, or the healthcare systems get impacted. Now, the advantage is also, like, if I'm held to the metric and my data definitions and interoperability is good, and they get their testing done for some screening in another system, I'll still get the credit because patient is tied up to my kind of thing. So again, there are all kind of things, but the reason we should do this is because of the patients. They require the best care which is possible.
Julie, why are we seeing that urgency today? Why are organizations so focused on this?
Well, I think there's a few things, right? I mean, InterSystems has been in the interop business for 48 years, right? We've been doing this for forever. But I do think there's a gradual shift that we're seeing. It is not just connecting pipes. We now all believe connecting pipes is not enough. Connecting pipes was hard. It's still hard sometimes, but it's not enough. We have to actually filter and clean and deliver what's needed. But we've also expanded what we're piping, right? We started with a really tiny subset of clinical data. Now we're really talking about more robust clinical data and all of the rest of the enterprise data, which means we can answer so many more questions if we get it right. Right, back to the fact that we all have to bill, we all have to, process all of our things. We need to know things about throughput. We need to know things about capacity. All of the different data sources that used to live separately can be combined together and can be usable if we do interoperability right. So that, back to your point, your dollar bill is always your dollar bill, and it means the same thing no matter who's looking at it. And it's a dollar bill, whether you're talking about it from a financial standpoint, whether you're talking about it from a billing standpoint, whether you're talking about it from a, right, everybody sees it and understands it the same way. And I think that that's really where we sit now, particularly when we think about AI moving to agentic workflows, doing actions on our behalf, that we have to have that confidence that we're all talking about that same dollar bill. And so it's not just connecting, it's connecting more things, and it's connecting them with the same meanings and the same cleanliness that's necessary to actually answer the questions that we're putting before it.
Dr. Valerian, go ahead.
We see technology as a major necessity for healthcare moving forward. And we reach out to those non-employed within our network, clinical areas, clinicians, and clinics to say, join the HIE integration because your data is very important to us and your patient care. And we're moving away. We have an anti-fax program and moving clinicians' use of technology into the modern day processes so that we get that information directly into our data lake rather than having to go jump through health information management on a CD and convert that into the EMR and put that in. Now the efficiency is there. It reduces the burden of care delivery. It reduces the financial impact. I mean, we calculated a year ago $3 million just on management of patient data in the old paper world CD records that we're going to eliminate. But we need to have collaborators, and those collaborators need to connect appropriately, not just internally with us, but externally to those primary care sites that we have patient feeders from, and laboratory and radiologic, so that we get the information that's accurate. So we have a complete picture of the patient and not just parsed pictures because some of it's in paper and some of it's electronic.
Well, I will be enrolling my parents in the anti-fax program. Thanks for mentioning that.
Welcome aboard.
We'll reach out.
We're on a
there.
process. Good.
Yes, yes. Dr. Weber, I want to spend a little bit more time. We've talked about scalability. We've talked about pilots, certainly. And again, there's a lot of talk about we have a pilot that runs. It maybe rolls out here and there, one or two departments, but then it just never scales. It's a trial. Some people trial it, and it just doesn't seem to work. How much of that stall out is a data problem in disguise, so to speak? And again, what does it take to build the right data infrastructure to move from a pilot to scale?
Yes, I think like pilot has become like either a dirty word or a penalty taxed word, because it feels sometimes like a pilot project. We've really tightened up sort of on how long we really let things go as a surrogate marker for that, because sometimes when we're talking about data readiness and we're like, okay, so it's not this, it's not like we're held up, we didn't move the data, or it needs to be transformed or de-identified in a way we didn't anticipate, and we'll say, okay, so then that wasn't scoped correctly. Like if we said it was going to take 6 months and at 4 months we still haven't done that, then it wasn't the right thing to do. So Lucas, I would say, like, in terms of we've tried to tighten up on that very much so that we don't start pilots that are not ready. Like, there has to be context and readiness of the data kind of as a toll gate to it even being viable. I think I don't know that we have. So for example, we have a precision genomics program that we run at IU Health, large amounts of genomic data that we have started to really, that's one of those use cases where I'm like, that is a great example of an amount of data that the human mind cannot assess in the same way that we have to use AI tools. Now, I see Julie laughing. I don't know if I'm not a geneticist or a genomic pharmacist. The way that genomic data comes and goes, that particular element, it can't be all the things all at once. Like, you can't just, as someone had said to me, well, let's just throw it into Chat GPT. And I was like, oh my goodness, that is not how that works. It's going to produce value. But when we designed that work, it was never scaled as a pilot because it was to serve the entity of that clinical program. Like, that was its footprint. And so we never really intended that particular use case to be used across other data sets. And so I think that's how we try to account for that. Now, what things and what percentage stall out before we're able to do them? I think it feels like 100% when it's one that you just have to say, nope, that didn't work. It feels like 100% of the projects, but I think that we've been really intentional, and I'm interested in my others here on the panel with clinical AI use cases. We're extremely specific about here's exactly where we expect to use it, and here are the things we're going to measure. For example, we have a non-medical translation tool. And we said, okay, for non-medical, I don't know how in healthcare anything is non-medical, but this was for our guest services and our environmental teams and our food services. We said, we're going to try it on these in this hospital. And if patient satisfaction goes up, the adoption goes smoothly, and our surveys are good, then we're going to scale it to the organization and it will be our system solution. That's an example of one that was really well done. The others that don't scale, I think the burden of the data readiness is so obvious that it's a lot easier to say, this is just not ready. It's just not going to work. And then you couple that with kind of acceptance on the clinical and other team member sides. I would say a lot of those projects don't even make it to pilot stage because the resources are so precious. Like we don't really want to put things in front of our clinicians at all until they've at least met minimal footprint. And we're probably more, at least in my organization, I feel like we're more intentional about things that are honored to be a pilot at this point than maybe we were 2 years ago, even a year and a half ago. We're like, well, let's try it. It says it can be done in 6 weeks. I think we've learned very quickly that's not usually a misnomer. So I don't have a percentage of the ones that stall out. I would say I hope we're better at only bringing things there that really do intend to scale. And then it's really clear when we need to turn them off. Like, this isn't working. We're done. So.
Dr. Kleber, same question for you again. I'd like to focus on that data piece too again. How much of these stallouts are typically related to data problems? Is that the case?
I think if you asked me this question 3 years ago, maybe like 6 years ago, the answer would have been yes, because there was somebody on that unit who was looking at these, pulling out data points and putting it into a flow sheet by hand. They were asking the patients targeted questions and on an iPad answering things. But today we, like what Dr. Weber said, we have governance around this to know before it starts that this shouldn't move forward. We know at the beginning, like I think we're also more comfortable saying, like, we're doing tons of other things. We can't go live in 2 units, except for when we're really confident that all we need is usability testing. So the pilot is mostly for really good usability testing. And then we come out of the pilot and we can expand out. I do think that data used to be one of those problems, but because it's become an enterprise problem in general, it's less targeted to pilots anymore, and it's more just in general, it's a thing that we think about going forward. And I think when we start to scale, it shows problems, but those problems were found, and either there's still a problem, so we know not to start the pilot, or they were fixed, and then we know the pilot could go and expand out from there.
Yeah. Dr. Valerian, go ahead.
I think it's just being logical about what you're doing as a leader, whether it be the car industry, airline industry, banking. You create guiding principles of practice that you all agree upon from an operational, clinical, and technical aspect. So you all see the same elephant at one time and say, will this elephant do something you want it to do? Will this AI agent or pilot do what we think it will do? If you don't achieve those 5 guiding principles, then that's a questionable project and focus on the other stuff. So that's an initial filter for a lot of what we look at and get rid of the chaff and look at the specific thing we want answered by AI.
Julie, really quickly here, do leaders understand the fact that it might be a data problem in disguise? Because again, if it's disguising itself, it might not be easy to identify.
I think we're all learning. I think, right? I think many more of us would understand that it's a data problem today. And I think it actually is surfaced in a number of ways. One, AI is not cheap. And the cost is it helps us evaluate more critically and actually refine proposals before they go out into the wild for use. And I think one of the reasons that we've started to see evaluation of that is because cost is a factor. And historically, we might have just said, we'll give it a try, we'll see, all of those things. And I think we've also seen early on that the volume of data can, genomics, great example, the volume of data can be so large that it's really hard to evaluate. And so sometimes we've had the tendency to say, let's just shove it in there and let's see if we get the right answer. And now we know we actually need to take a look at it to make sure we're putting in the right thing in order to get the right answer. And so I think data has become part of that conversation always, right? And I think that has been really refining in terms of the evaluation process any organization is going through to say, do we want this initiative, whatever this initiative is, to move forward? Because have we really checked all the boxes that are needed to get it there? And we're not willing to be as flexible as maybe we would have been in the past, which means we're also willing to say no a little bit more. And that's actually getting us to more successful initiatives moving forward.
I feel like we could keep going here with this conversation. It's been so incredible. We're almost at time. I want to close us out on a quick fire round here. One of my favorite things to do with you all. I want to ask you all, right, as we're looking at this process, as organizations are trying to determine how to turn fragmented data into insights and certainly scale them, again, what's that one action you want leaders to take today? What do you want them to do? What's that one thing they need to start to move in the right direction? Dr. Chada, I'll start off with you.
I think deciding what skills are good to keep and makes us doctors, and what skills we can let go. There is not a national standard or a professional standard for that. We have to come to that consensus, because I don't want to continue relearning things which are non-value added, while there are some things which I cannot let go.
Dr. Weber, what's your one thing?
I think I'll build on that a little bit about our discussion. I think this is everyone's responsibility in terms of data and AI literacy overall. And I think the challenge is to continue to build each of our healthcare leaders to a level of selecting and identifying the right opportunities. And at the same time, to Dr. Chatter's point, like, it becomes part of healthcare training to know how you work in this new space. How do you use these tools in a way that's safe, effective, and ethical in the care that you provide? So I think that's the charge, the universal charge, is like, this is not an IT knowledge base alone. It's not an informatics alone. It is all of us having a higher level of understanding about what these tools mean to our patients and for success.
Dr. Gleber?
Yeah, I think I'll build on that, and maybe I'll more target of what could you do right now. Is don't try and be perfect. If you try and be perfect with everything, you won't get anything done. But if you pick a really highly valuable data space, and you can make a data product to help you in that one space, you will uncover problems that you can fix in the other spaces that will just naturally happen. So I would say, start small if you are at the beginning, but you could start medium with one data domain and start with the building from there, and this stuff will get fixed in time, and then you can start doing these things very quickly.
Yeah. Dr. Valerian, what's that one thing you want leaders to start doing?
Two things that are intertwined. One is relevance. Make sure it's relevant to your mission. Make sure what you're doing is aligned to your annual goals, so that they say, yes, if I follow what we're doing and collaborate with you in AI, then I will achieve my goals, which is the next level of adoption. And the other piece is the end user upgrade. I call it the end user upgrade because we have to bring those folks who aren't ready to adopt into the fold and help them achieve just the adoption level. Then they're ready to utilize the data level. So we have to take those three levels and integrate them and advance that. So we're doing that with clinical informatics rotation education through our department, as well as clinical monthly rounds for GME for our clinicians to understand what AI is and give them a little homework and stuff. So there's an interest there to buy in to what we're doing, so we all move forward together.
Julie, again, from your perspective, what do you want leaders to do? What's that one thing for you?
I would say we have to ask the right questions, and the right questions are really about how to deliver the best care for the patients, right, as healthcare organizations. And that may mean AI is the way to go. which may mean data readiness needs to be looked at. But it needs to be for a purpose that actually impacts the lives of the people we're responsible for. And that may require different tools, different approaches, different training. But if we keep the right focus, then we can actually get to how to solve this problem in a meaningful way with a trusted partner. And I think that's really essential.
Well, I want to thank you all so much for taking some time for us today. What a great conversation. We traveled from Data Lake to Jurassic Park, which I very much enjoyed. I want to thank you all so much for taking the time. I want to thank our audience for being here and listening to us. I want to certainly thank InterSystems for bringing us together for this wonderful conversation. And again, thank you so much for joining us, and I hope you have a great rest of your day. Thank you.
Thanks.
Thanks.
Thank you so much.